Hi, everybody. Welcome. I'm Sharon Anderson, and I am president of Leiomyosarcoma Support and Direct Research Foundation, or LMSDR for short. I'm also a 21-year this year survivor of leiomyosarcoma. Today, we are very grateful to have Dr. Ankit Mangla with us. He is an oncologist and sarcoma researcher at the University Hospital Sediman Cancer Center in Ohio. Dr. Mangla will tell us about the TTI 621 with Doxorubicin trial for leiomyosarcoma. So with that, I want to thank Dr. Mangla for coming and welcome him to start presenting.
Thank you, everyone. Thank you so much for inviting me over to talk about this pivotal trial we are doing in patients with leiomyosarcoma. And with that, I would like to start my presentation. It's a little bit longer presentation because I also included some information about begin with general sarcoma discussion. So I will start sharing my screen here. All right, you can see my screen, right?
Yes.
So yeah. All right. So I am Dr. Mangla. I work at Sediman Cancer Center, and I'm affiliated with Case Comprehensive Cancer Center in Cleveland, Ohio. And this is the place where we work, Sediman Cancer Center, and Case Western Reserve University School of Medicine. So to begin the discussion with sarcomas, all solid tumors are divided mainly into two categories, like they're epithelial and there can be mesenchymal. Epithelial tumors mainly arise from the lining of the body, which is called as epithelium. They're called carcinomas in usual, and they constitute 90% of all the cancers, solid tumor cancers we know of. Mesenchymal tumors are the ones that originate from the connective tissue of the body. They could be muscle, blood vessels, lymphatic systems. These are what are called as sarcomas and are not very common. They constitute less than 1%. They constitute approximately 1% of all the cancers. Now, sarcomas are known to be more common in kids, but it's not the most common cancer in kids. It is known to be more common in younger population with kids and adolescent young adults. But as you grow old, sarcomas tend to become more and more fewer. Leiomyosarcoma is one of the more common kinds of soft tissue sarcomas, constituting around 15 to 20% of all soft tissue sarcomas. According to WHO 2022 classifications, there are almost over 150 different kinds of sarcomas that have been described. But still, LMS is one of the more common ones. It happens more commonly in adults compared to children, in women more than men, and it tends to be more of uterine origin compared to non-uterine origin, which can occur in extremities and blood vessels. It is of a smooth muscle cell origin, and muscles are present everywhere in the body. It can literally start anywhere in the body. Mostly people are asymptomatic unless the sarcoma reaches an advanced stage where they start experiencing unintentional weight loss, out of proportion fatigue, loss of appetite, night sweats. When women with uterine leiomyosarcoma may experience acyclical bleeding or postmenopausal bleeding, which are all signs to be checked out, like to be made sure that your physicians are looking for untoward diagnosis like cancers. Any kind of cancer can give this kind of symptoms. So treatment of leiomyosarcoma is based mainly on stage and location. As you can see in this table, surgery is the first line of treatment for any kind of localized leiomyosarcoma. Radiation or systemic treatment is recommended based on the location. For example, in retroperitoneal leiomyosarcomas, there was a recently concluded large STRASS-1 study from Europe that said that radiation therapy, preoperative radiation or postoperative radiation for retroperitoneal LMS is of no benefit. So we have moved away from that most institutions, and we just go for surgery versus with or without systemic therapy. When a patient is diagnosed with metastatic leiomyosarcoma, systemic therapy is offered. as a first line. In that, in many patients ask me like if they can do surgery or if they can do radiation. We use those modalities only as a palliative measure to help control symptoms. Now, of course, it is a case-to-case basis. Some people have less metastasis, which can be tackled with surgery or radiation, and we have done that. We have used that in those situations, but more mainly it is systemic therapy that we go to when it comes to metastatic disease. Now, systemic therapy for non-uterine leiomyosarcoma is a little different from that from uterine leiomyosarcoma. However, first line regimens are mostly anthracycline-based regimens. In the US, we prefer to use doxorubicin. There are other anthracyclines which are also popular in Europe. Epirubicin is one of them, which is popular in Europe. A leiomyosarcoma that starts outside the uterus, most physicians will prefer doxorubicin combined with dacarbazine. And there are several trials that are going around right now, but the best and the most promising trial that is going is the doxorubicin and the trabectedin trial, with the most promising data that has come out so far, which has increased the PFS, progression-free survival in patients with the non-uterine LMS in the metastatic setting. Second line choices are trabectedin, pazopanib, dacarbazine. We usually do not prefer ifosfamide for non-uterine leiomyosarcoma, and also gemcitabine and docetaxel. Like there is research showing that these agents don't work very well in patients with non-uterine leiomyosarcoma. In the uterine leiomyosarcoma, again, anthracyclines are still the first line of treatment. However, ifosfamide has more activity in uterine leiomyosarcoma. That's why we try to use doxorubicin. Ifosfamide is the most preferred agent we use here. And again, the same doxorubicin trabectedin trial has shown a good promise in patients with metastatic uterine leiomyosarcoma. The second line choices, of course, gemcitabine docetaxel is more preferred in uterine LMS. There was a trial which called Gedesis trial. It used gemcitabine docetaxel as first line. It was a non-inferiority trial and showed that gemcitabine docetaxel combination was not inferior to doxorubicin. But that trial has been criticized in the US for a design that was not considered to be a standard of care for the patients, like how we treat patients in the US. Then second line choices, again, trabectedin, pazopanib, dacarbazines, those are other second line choices. In indolent diseases where where the tumor expresses estrogen progesterone receptor, we can use aromatase inhibitors as well, but this is not recommended mainly for disease that is aggressive. Response rates. So what do we mean by response rate is basically when we do CT scans, we should see shrinkage of the tumor. So how much shrinkage we are noticing leads us to determine if a patient is what kind of response the patient is experiencing. If the tumor disappears from the scan, we call it complete response. If the tumor is shrinking in size but is not disappearing from the scan, we call partial response. Stable disease is when the tumor remains the same size. All these three responses are acceptable to us, and as far as we are able to prevent the growth of the tumor, that is considered to be a success. First line treatment, mostly it gives you a best response rate of 35%. You choose any of the first line treatments. And with second line treatments, as we go along, the response rate keeps dropping. And again, it is less than 15% in most studies. Major challenges, when we talk about major challenges in leiomyosarcoma, it's the heterogeneity within the tumor. With lack of molecular characterization, there is so much molecular heterogeneity within leiomyosarcoma that it becomes hard to say one shoe fits everybody. As we have to understand the approaches need to be tailored a little bit once you enter into a metastatic realm and treat a patient with stage 4 disease. So that is why next generation sequencing, genomic sequencing is coming to the fore. where we want to understand what is the molecular makeup of the tumor, and if there are any targets that can be expressed, if there are any mutations that the tumor expresses, which we can use in the future for targeting that particular mutation. There are drugs that are approved for other cancers. For example, I had a patient once that expressed a BRAF V600 mutation. So there are drugs that are used in melanoma that target that mutation, and we could use those drugs. We could use those drugs in that particular patient with leiomyosarcoma to help that patient. So genomic sequencing is important. You should request your physicians to run genomic sequencing on the tumors, and most physicians are doing this, I mean, regardless. So we come to the next point is the immunotherapy. Immunotherapy has been coming to forth big time. It's approved in different cancers. It uses your own immune system to fight the cancer. So how is your immune system built? So this is basically a very simple schematic diagram of your immune system. Now, the whole body has immune system in different organs play a part as immune system in different areas. Like in the head and neck area, your tonsils, adenoids, thymus, lymph nodes, they are the part of your immune system. Lymph nodes are present everywhere, from head and neck region to axilla to groin, and there are small lymph nodes, lymphatic chains that are present everywhere in the body that are part of your immune system. Now, immune system is largely divided into two parts. One of them is the innate immunity, and the other one is the adaptive immunity. Innate immune system is the one that is the immediate response of your immune system to a foreign body, to a foreign organism. Suppose a pathogen tries to attack through your skin. The cells which form the innate immunity, they are not very specialized. They attack anything that they perceive as foreign. So that is what innate immune system is. And then adaptive immune system is a more sophisticated kind of response from your immune system. Once a foreign pathogen attacks the body, and the innate immune system collects information from that, particularly macrophages, and they take it to the cells that form the adaptive immune system, to the B cell or T cell, and they show them the antigen, and then these cells learn how to respond to that antigen if they see that antigen in the future. So that is why innate immune system, like we break it down as a rapid response, and adaptive immune system is a slower response. So right now, if you Google the word immunotherapy, frankly, you'll see all these things popping out there. Immunotherapy, there are different kinds of immunotherapy. Mostly when I see patients in clinic and I talk to them about immunotherapy, their first response is that it boosts your immune system. We have developed various techniques to tackle the immune system in multiple ways. And these are the kinds of immunotherapy which are currently either under investigation, or some of them are FDA approved for treatment of various kinds of cancers. Interleukins, interferons, vaccines, chimeric antigen receptor T cells like CAR T cells, they're very popular in liquid malignancies and leukemias. Checkpoint inhibitors are mainly what you hear of drugs like pembrolizumab, nivolumab, ipilimumab, those drugs, and many other drugs. They are the ones that are more popular in solid tumors. Tumor infiltrating lymphocytes, currently they are not approved in the US, but most clinical trials in melanoma are showing success. So there may soon be a regulatory approval. And T-cell receptor engineering therapy is much like CAR T-cell therapy, and this has also been developed. But yeah, so currently checkpoint inhibitors, there are over 9 different kinds of checkpoint inhibitors that are approved for 17 different cancers. And this is a comprehensive list of all the drugs that are approved. Major trials of these checkpoint inhibitors in patients with sarcoma have resulted. The first one was 028, which was looking at pembrolizumab alone in patients whose tumors had progressed on first line on previous chemotherapies. So that study showed that immunotherapy, the single pembrolizumab alone, did not have any response in bone sarcomas, but it had some response in soft tissue sarcomas, mostly in patients with undifferentiated pleomorphic and sarcoma and liposarcomas. So they expanded their trial into these patients, and eventually they found that around, give or take, around 20% patients responded in the UPS cohort, and around 10% patients responded in the liposarcoma cohort. Then there was a bigger trial led by the Alliance Oncology Group, which was comparing ipilimumab and nivolumab versus nivolumab alone, again in a relapsed refractory setting, where they found that the combination was again giving response in 6 out of 38 patients, and nivolumab alone was giving response only in 2 out of 38 patients. Many other promising approaches are present. I mean, at this point, combining checkpoint inhibitors with chemotherapy or with targeted therapy. One of the most promising one was the first line of the pembrolizumab and doxorubicin, which has shown that PFS doubled, and now they're trying to expand this into the cohort of UPS. So currently, we know that the subsets that show activity with checkpoint inhibition are alveolar soft part sarcoma, undifferentiated pleomorphic sarcoma, myxofibrosarcoma, angiosarcoma, and dedifferentiated liposarcoma. Ipilimumab and nivolumab combination showed some activity in leiomyosarcoma. It is around, it's less than 10%. So it by itself, immunotherapy did not generate much excitement in leiomyosarcoma. But there are certain subsets of patients who can have exceptional responses from immunotherapy. The first one is the patients who have high tumor mutation burden. Now, these tumor mutation burden is something that we can determine through genomic sequencing. So we know from clinical trials that there have been research showing that patients who had high tumor mutation burden, they will respond to anti-PD-1 therapy, which is checkpoint inhibition. So US FDA did approve pembrolizumab in such a setting where for any kind of cancer, any kind of tumor that expresses a high tumor mutation burden, US FDA has approved pembrolizumab for that. However, we have to be cautious in interpreting this because many times, many kinds of cancers were poorly represented in these trials, and sarcomas was one of them. So it may not, I mean, again, one size does not fit everyone, although it is always beneficial to try, Keytruda or pembrolizumab in a patient with expressing high tumor mutation burden. This is also important in letting us know that, genomic testing for genomic sequencing is important in patients. That is where you never know. I mean, there's no way to predict who will have a high tumor mutation burden. So, like, for example, in patients with cutaneous angiosarcoma, which it happens on the skin, especially of the face and head and neck, it's associated with UV damage. And we know, we can, all the studies that have been done, they're very small patient samples of around 4 or 5 patients, but have consistently shown that these patients have high tumor mutation burden. So it's always a good thing to ask your physician to run genomic sequencing. The second is the patients whose tumors are deficient in mismatch repair gene. Again, this is found on the report of your genomic sequencing. It is also called as microsatellite instability high. And pembrolizumab has been approved for such tumors in relapsed refractory setting. And we have had patients in several tumor types that express that are deficient in mismatch repair genes, and they have been they have responded to immunotherapy. The chances of that happening in patients with any cancer is, especially in sarcomas, is very few. It's less than 2% in leiomyosarcoma, but again, like I said, genomic sequencing will tell the physician as if this is the case or not. And if it turns out to be the case, then immunotherapy may succeed. So we come to our trial, which is TTI 621. So macrophages in our body, they form a part of our innate immunity. They are basically, like I said, they are the first responders to any foreign pathogen. And CD47 plays a role in our body by preventing the activity of macrophages against normal cells. So there were experiments done in mice in which they said, like in which they infused red blood cells into mice which were lacking CD47, and they saw that immediate phagocytosis, like immediately macrophages chewed up all those RBCs. So we know that CD47 expression on normal cells is a way of the normal cells telling the macrophage system that, please don't eat us. And as those cells grow old, the expression of CD47 keeps going down, which is how macrophages are able to recognize older cells and keep clearing them from the body. Cancer cells also exploit this mechanism. They use the CD47 to escape the macrophages. And it is known in patients with osteosarcoma that if they have high levels of CD47, they have a poorer prognosis. Now it doesn't, we can just tell them that, we can just tell the patient may have a poor outcome, but does it impact the way we treat him or her is not different. We from also in patients, so SIRP alpha pathway is expressed on the macrophage, which couples with CD47s and dampens the activity of macrophage. And again, in patients from myxofibrosarcoma and synovial sarcoma, we know that if there is high level of SIRP alpha on macrophage, it will also confer poor prognosis. So there are also liquid tumors like acute myeloid leukemia, Hodgkin lymphoma that we know about this activity. And TTI 621 has been tested in those patients too, in those disease settings too. So in this trial, it's a novel CD40. TTI 621 is actually a novel CD47 blocking agent. And the added advantage is that it is also has a built-in macrophage activation signal. So if you look at the diagram, the purple part of the diagram, the SIRP-alpha it's the domain which binds to the CD47 on the tumor cell and blocks the don't eat me signal. And then they also added a IgG1 Fc receptor, which combines with the macrophages, which combines with the Fc gamma receptor on the macrophage and delivers a stimulatory signal to the macrophage to act on the tumor cell, which is binding to the SIRP alpha domain. So it's a kind of a two-hit mechanism. They're not only blocking the signal on the tumor cell, which is the tumor cell uses to hide from the macrophage. They're also linking the macrophage to the tumor cell and activating the macrophage to eat the tumor cell. So that's a novel mechanism that they have developed in this kind of sarcoma, trying to hit the sarcoma where it hurts the most. So in this trial, we are combining TTI 621 with doxorubicin, which is, like I said, is the first line of treatment, first line of treatment in the US for patients with metastatic leiomyosarcoma or with undifferentiated, locally advanced, unresectable leiomyosarcoma. So the way this is designed is that patients will receive doxorubicin at 75 milligram per meter square every 3 weeks. This is the standard dose which we use for 6 cycles, or at least for 4 cycles, which means that if the patient after 4 cycles we see that doxorubicin has caused side effects, then we can potentially stop the doxorubicin and the patient will still be allowed to be on the trial. The TTI 621, which is over here, the TTI 621 is given on day 1 and day 8 till the time the patient is on doxorubicin. When the doxorubicin ends, which is after 6 cycles or at least 4 cycles, then the TTI 621 will be given only on day 1 and day 15. And that treatment will continue on till either patient has a side effect or patient has progression of disease, or they finish at least 2 years of treatment. So patients who will be included in this trial, patients who have either metastatic or locally advanced unresectable leiomyosarcoma. Basically means that the tumor is not metastatic, tumor has not spread to other organs, but is so big that the surgery will either be too morbid or cannot be conducted safely without causing significant damage to the patient. So, or it's not possible to operate. So those patients are allowed to participate, will be included in this trial. The trial only allows patients with high-grade leiomyosarcoma, both uterine and any kind, both uterine and non-uterine. So the important part is that patients with low-grade or intermediate-grade leiomyosarcoma will not be included in these trials. And the patient should be doxorubicin naive, that they should have never received doxorubicin before. They're allowed to receive one line of treatment before receiving doxorubicin, so, and that too with gemcitabine and docetaxel. If the patient has received more than one line of treatment or chemotherapy with a different kind, then they will not allow the patient to then the protocol doesn't allow the patient to participate. So what is high grade mean? What is the grading system? The grading system is based mainly on the French system. It depends on 3 things, which is tissue differentiation, mitotic count, and necrosis. Tissue differentiation means how much does the cancer cell look like a normal cell. So when a cell becomes cancerous, it can either completely lose similarity to its parent, to the normal cell, or it can look like a normal cell but still have features which suggest that it is cancerous. So the tissue differentiation of 1 means cancer cells look like a lot like normal cells. A 3 means that it has absolutely no resemblance to normal cells. Again, mitotic count is number of cells that we see actively dividing in the microscopic fields. Again, number 1 means less number of cells are seen as a dividing in the microscopic field. 3 is the higher number. Necrosis is also dependent on how much tumor is made up of dying or dead tissue. So a pathologist looks into a biopsy sample or a surgical specimen and adds up, gives this grading to all these 3 things based on these 3 things, and then adds the number up, and then comes up with a number that basically classifies as to what is high grade, low grade, and intermediate grade. So of course, all trials want patients who are able to participate without causing too much harm to the patient. So they have certain criteria based on which they will exclude certain patients. So since patients are going to receive doxorubicin or an anthracycline, anthracyclines have a history, the biggest and the most revered side effect of anthracyclines is cardiac side effects. It can affect the heart function. So any patients who have had a cardiac event within 24 weeks, has uncontrolled hypertension, heart failure, those patients will be excluded from this, will not be able to participate in the trials. Now, since we are also taking away we're giving the drug that blocks the CD47 and allows the macrophage to attack the cell, and we know that CD47 also is expressed on normal body cells, we have to be sure that the patients do not have an autoimmune disease. So autoimmune diseases which are requiring active treatments. So there are some patients who are diagnosed with autoimmune diseases, but they are not requiring, like their disease never required treatment or required that they had a flare which was more than 2 years ago. So they may be allowed they may be included in the trial, but it's a discussion with your physician who's running the trial. Anybody who has received an organ transplant. Now, organ transplant, whenever patients get organ transplant, they require immunosuppression because we do not, the transplanted organ is a foreign organ in your body, and we are trying to protect that organ from your own immune system. So that is, anybody who's received an organ transplant will automatically be at a higher risk of organ rejection with this trial. That's why they are not allowed, they are not included in the trial. Any patient has another cancer that is requiring treatment. Sometimes two cancers exist in same person. So many times it is the other cancer is completely indolent, which is not like it is there, but it's not doing anything. So we can include that patient. But if that cancer also requires treatment, then that patient will not be included. Again, anybody requiring anticoagulation-based therapy except for heparin-based therapy. So TTI 621 for some reason has been associated with increased incidence of thrombocytopenia, which is low platelet count. So the trial allows for patients, so patients, if they have a blood clot, the trial is allowing the patient to enter if they are being treated with enoxaparin or Lovenox and other heparin-based anticoagulants. But if you are receiving drugs that are the pills, the DOACs, the one we call like apixaban, rivaroxaban, then the trial will not allow you to. Then the trial doesn't accept those anticoagulants. Patients will be excluded, and they also exclude patients who have had prior radiation to mediastinal or pericardial area, which is basically the chest wall. Because suppose somebody had breast cancer and had received radiation for that, or had a lymphoma in the past and received radiation to the chest area, it is known that when you radiate the chest area, the radiation spills over into the heart, and it causes long-term damage to cardiac walls, pericardium, the sac of the heart, and it can cause it can exacerbate, those effects can get exacerbated when anthracyclines are given. So they will be excluded from the study. So those are major exclusion criteria. Of course, there's a lot of more finesse that is in the exclusions and inclusions. So if somebody is interested in the trial, then it is best to reach the sarcoma center that is offering it and check out with them whether they can be included in the trial or not. TTI 62103 is registered in clinicaltrials.gov, and it's open in 21 different locations across United States. On the West Coast, it's in Los Angeles, in the Washington area, and on the East Coast, there are more than different areas that are running the trial. In Ohio, we have the trial here at Sediman Cancer Center. And so far, we have successfully recruited one patient in the last 6 months since we have opened the trial, and we are continuously looking for more patients to help them. In this forum, I also want to discuss one more trial that we are running at Sediman Cancer Center, and is a very promising trial. It's called the CAB-AXL antibody drug conjugate. So if you look at this diagram, this is literally the diagram that expresses most of the receptors that are currently being explored for various ways on how to tackle the leiomyosarcoma cell. So AXL is one of the receptors that is expressed on the leiomyosarcoma cell. Now, however, the thing is, it is not expressed homogeneously on all patients with leiomyosarcoma. Some patients may express less amount of AXL, some patients may express high amounts of AXL. So there is the company has developed, the pharmaceutical company has developed a drug which attaches a molecule with the AXL, with this receptor, and leads to response. Now we'll show it in the next slide. So this is how an antibody drug conjugate works. So suppose this is the tumor cell, and this is the antigens are these little red spikes that are being expressed by the tumor cell. And the antibody is the Y-shaped molecule which you see. And the chemotherapy are these small sprinkles that are attached with the antibody. So once we inject the drug into the body and it travels around the body, it will find these spikes on the tumor cells, and the antibody will attach to the spikes on the tumor cell, which is the antigen. Eventually, the tumor cells think that this is food, so they start engulfing the antibody, which is a process called endocytosis, and the tumor cell will eat the antibody. But what it will not realize is that it also has eaten the chemotherapy molecules that are attached to the antibody. Now, within the tumor cell, there are other organelles called lysosome, which contain digestive enzymes like protease. The job of protease is to break down all the endosomes and digest whatever is inside the endosome to help the tumor cell give nutrition to the tumor cell. So proteasome will attack the endosome and will break everything inside that endosome, not knowing that the chemotherapy is now being released inside the tumor cell. And once the chemotherapy is released inside the tumor cell, it will lead, like chemotherapy is released, and it will lead to cell death. So this is kind of a beacon mechanism, which we say that there's a beacon inside the tumor cells, and we have basically launched a warhead which will track the tumor cell using that beacon and attack it. Now, the interesting part is that when the cell dies, the chemotherapy molecule doesn't die with it. It actually is released into the tumor microenvironment. And the cells that do not express these antigens enough number, even they can receive these chemotherapy within their microenvironment. So it kind of affects both, the cell that is being attacked and the cell that is not being attacked. Now, so BA3011 is the investigational product that is using this mechanism where we say this AXL antibody and uses AXL as the antigen for the cancer cell, and the ADC is and that's how the drug has been developed. But it is also one more thing that is unique about BA3011, that it's a conditionally active biologic. So what does that mean? Basically, what it means is that this drug, when the combination goes in, there's always this issue that the drug may also, AXL may be expressed by normal cells too, and they may ingest the drug and cause the chemotherapy to be released in that environment, in the environment of the normal tissue. Well, conditionally active biologic is, they have designed the drug in a way that it will skip the area where there is normal tissue, and it will try and attack only the areas where there is cancer cell present. So this is a very interesting molecule, and we have been running this trial for nearly a year or so. And the only hitch is that when we have to do the trial, it's the requirement of the trial is that we have to look for AXL expression on the tumor cell. So biopsy will be taken from the patient and sent to the central review, where they look for the AXL mutation and expression on the tumor cell, and then they come back to us saying that if the AXL expression is high, then the patient can enroll in the trial. If the AXL expression is low, well, then that is a thing that then that patient cannot go on the trial. Of course, all kinds of leiomyosarcomas are allowed. All kinds of patients, all kinds of leiomyosarcomas are allowed, meaning both uterine and non-uterine. That there one requirement is that the patient must have received an anthracycline in the previous lines. They will allow up to 3 different kinds of treatment in previous lines. You have 3 different kinds of agents being used to treat. And then again, like I said, tissue needs to be tested for the AXL mutation burden. So wait time for us before the enrollment on the trial So when we consent a patient for biopsy, we biopsy the patient, and then it takes around 2 weeks, 2 to 3 weeks from that time before we know that if the patient can participate or not. So that is something, again, it's open in 34 different locations, including ours in Cleveland and University hospitals. And we are actively looking for patients for this. We are also opening a new trial, which is olaparib and temozolomide versus usual treatments for uterine leiomyosarcoma. This is only restricted to patients with uterine leiomyosarcoma. And this is a trial that is coming from the Alliance Cooperative Group, which is a cooperative oncology group of different institutions with different sarcoma centers. I mean, it's different institutions in different cancers, but the sarcoma group at Alliance is starting the trial where patients with the metastatic leiomyosarcoma who have progressed after first line of treatment, they will be randomized between olaparib, which is a PARP inhibitor, and temozolomide, which is an alkylating chemotherapy. It's a pill, it's not an infusion, both are pills, versus physician choice, which is either trabectedin or pazopanib. It's again in the relapse refractory setting. It's currently open in New York, but it is coming soon to our university hospitals. So with that, I will end my presentation, and thank you so much for listening to me.
Wow, thank you. I have a renewed appreciation for researchers and everything they know. It's just such a comprehensive presentation. We thank you for that. So we do have some questions in the chat box. Let me read some of them. So Denise asked, and I think this is about the TTI 621 trial. More than one line of treatment other than Gem-Tax is not allowed, even if we are doxorubicin naive.
Yeah, that's a strict criteria which we have seen from them. When we try to recruit a patient, like I said, we try to make sure that the patient is has no treatment. It's completely treatment naive. But the only chemotherapy they allow currently on the trial is gemcitabine docetaxel.
Okay, so that's the only one they do allow in that trial. Okay. Will AXL be listed on the list of gene mutations? I guess someone's had next generation sequencing.
Yeah. So it doesn't matter if it's expressed or if it is listed on the mutation on the panel of, on the gene panel. It's the amount of expression on the cancer cell. So, I mean, at this point, we don't know how they are determining this, but it is basically we have to take the tissue sample and give it to the pharmaceutical company that is running it, and they have their own mechanism of determining how much is the expression. So what I'm trying to say is that you may have AXL gene mutation, but if your expression is low, which is, I mean, I'm just arbitrarily saying 20%, say, so the trial will not be a good fit for you.
Okay, so one of my questions was, where do we get the AXL test?
Also, it will be with the center that is running the trial.
Okay, so you would apply to that center, they would do the test and see if you qualify.
So yeah, so the way it works is that you come to that center, the physician will give you a consent form. You basically consent to having your tissue tested for the AXL, the burden of AXL mutation. Then we send after the consent, we send the tissue. Now it could be an archival tissue also if it is within 1 year.
Okay.
So if somebody had a diagnosis made and then had first line doxorubicin, it unfortunately did not work, then the patient's that biopsy tissue can be used for testing if it is within 1 year. If it is after 1 year, then the trial requests a new biopsy to be done.
Okay, we had another question. Could you have had Doxil instead of doxorubicin to qualify for the trial?
No, they will not.
No.
Liposomal doxorubicin is still doxorubicin. I mean, it's just that liposomal, the way it is developed is pegylated doxorubicin, that research studies have shown that it doesn't affect the heart that much. It doesn't go to the heart, so that's why it was from cardiac safety point, liposomal doxorubicin has been used. Nobody has ever, like there is some anecdotal evidence about comparison efficacy of doxorubicin versus liposomal doxorubicin and doxil not being that inferior, but really no formal studies exist so far.
Okay,
So, but it is still doxorubicin, so yeah, TTIC.
so it disqualifies you. Okay. What percentage of people are responding to this trial, the TTI 621?
So we don't have the data yet. I mean, that disclosure is not made. Because I mean, we are not allowed to. I mean, we as investigators also are not allowed to look into what is happening in other institutions. I mean, one thing I would say is that, when I counsel somebody for the trial, I always tell them that, look, I mean, you are getting standard of care. For me, as a physician, even if I think myself as a patient, I mean, number one thing I think of myself, think is about a trial is there a placebo involved? Will I not be getting the drug? That is not the case. I mean, you will exactly know what you are getting. You will be told what you are getting. Number two, when I get a drug, will it be an inferior? Will I go to an inferior arm? So in sarcomas, usually we don't say that there is a standard of care. Like in breast cancer, we say that, doxorubicin based therapy is the first. Doxorubicin cyclophosphamide is usually the standard of care, which every institution will do. I mean, doxorubicin anthracycline based regimens have shown the most success. So it's kind of a given that most institutions will practice giving anthracycline first. But again, it is such a heterogeneous group of tumors. Some institutions, or even I sometimes prefer giving gemcitabine docetaxel first, based on performance status of the patient, what the patient can tolerate. So I tell the patient that in this trial, we are giving doxorubicin 75 milligram per meter square, which is standard of care, which is most effective regimen we know of. So you are getting that. Now, adding this drug, will it help? That is yet to be seen.
Okay, good to know. So if there is shrinkage, if they're in the trial and there's shrinkage, how do you know which drug is causing the shrinkage, the doxorubicin or the immunotherapy drug?
This is fantastic question. We can never tell you that. We can never say that because it is not a randomized trial. So I mean, in the end, at some point, it may be asked of the drug company if this. So the way this trial is designed is that we have a set standard of, like I said in one of my slides, we know that approximate response rates are almost 35%. So the drug company has done statistical calculations, and they have said, like, for example, they say that combining the two drugs will improve the response to 60%, or they predict that the response will improve to 50%. And that's when they use those statistical models to come up with what we call as a power of the study, which basically means how many patients do we need to statistically show that this combination will reach that number.
Okay.
And that is how we decide how many patients will be enrolled or allowed on a study. So if we see like a 55% response, we predicted the combination will give 50% response, we need 100 patients, and we see 55% response in those 100 patients, then that is success. That is means we have reached our statistical significance. So then the FDA, then we take that application to the FDA. FDA will say that, oh, this looks very nice, let us approve this. Or they may say that, now you need a randomized control trial, which is most likely still the case, where they combine the combination and they compare it to patients who get single agents. And then we will know what wins.
Okay, all right. So Jocelyn has a question. If you have had SBRT for lung nodules, will you be excluded from the trial due to the radiation? No. Okay.
If you just had radiation, no, I don't think so. But if you had a targeted therapy along with radiation, some people had chemotherapy, some people had targeted therapies to radiation sometimes for whichever organ. I mean, then then that may exclude you, but just having radiation or surgery will not.
Okay. How about the UK? Can they get into the trial? Do they have the trial in the UK is actually the
I
question.
don't think this trial is open in UK, but you may have to double check for me.
Okay, we can check it out. Is the trial still open? The answer is yes.
Yes.
And there's several locations, which he showed the map
21
of.
different locations, yeah.
Yeah, and if you go to the clinicaltrials.gov and look at the protocol, you can see the actual locations and who to call for each location. Okay, I'm going to skip. How do you know if LMS is uterine or non-uterine? That usually is done at diagnosis. I don't know. Do you have a comment on that?
Yeah, I mean, usually is the point of origin, like in men, I mean, it will always be non-uterine. In women, so in women, it's we know, like it's basically the anatomy of the tumor where it starts. There's not a requirement of a genomic test or something that will tell you whether it's uterine or not uterine. I mean, I have had patients, women who had leiomyosarcoma starting from the inferior vena cava in the IVC or in the retroperitoneum too, but it did not come from the uterus. So heterogeneity exists. So it's mainly the anatomical location from where the tumor starts.
Yeah, we've also seen people test for estrogen receptors who are non-uterine and find that especially in retroperitoneal leiomyosarcomas. So that's another target that people can consider if they're low burden.
Yeah, I mean,
or low grade, I should say.
There are incidences in which the fibroids, the leiomyomas, have broken away from the uterus and traveled and implanted retroperitoneum and then developed a sarcoma in them. So that's truly not a non-uterine LMS, but that's where the challenge comes sometimes. That what is really uterine and what is not non-uterine, but mostly from anatomy we can talk about like what is what.
Okay, Vicky wants to know, is there good or bad necrosis?
Necrosis is necrosis. Necrosis mainly means dying tissue. So there is nothing good or bad about it. I mean, it's just that sometimes necrosis happens when we give treatment, which basically the cancer cell is dying. Sometimes necrosis also happens when the tumor is growing at such a pace that it outruns its own blood supply. So then it can happen automatically also, but that's not a necrosis which you are looking for because the tumor is rapidly expanding. You are more interested in a necrosis that happens with treatment.
Right. So that would be your good and bad.
Yeah.
Okay. Can LMS also have testosterone receptors?
I have not heard of that.
I haven't either.
So, no.
It's a good question.
Again, I mean, it's point, where does it start from? So it's like I said, it's starting from the smooth muscles. I mean, if it starts off in the smooth muscles of testis, maybe, I don't know, but I have never heard of a testosterone receptor being tested for in LMS.
Okay, let's see. Cindy asked something. What if BRCA2 positive in a tumor? What if BRCA2 positive in a tumor, but not sure it's genetic? Does BRCA2 positive make a difference in treatment?
So again, we cannot, when somebody has any mutation that is positive, we know that it doesn't make the tumor more aggressive. We cannot say that this is what makes the tumor aggressive or not aggressive. The idea of doing genomic sequencing is to see if we can use that mutation for targeting. So if somebody for reason have a BRCA2 positivity being shown in the tumor, we can potentially use medicines that target that mutation. So olaparib is one of those, and there are other PARP inhibitors also that can be used potentially in these patients. Now, BRCA2 is happening at two levels. One of them is called the somatic mutation, which happens in the cancer cell. And then the other one is the genetic mutation, which is in your genetic makeup. So if somebody has mutation in the genetic makeup, I mean, we can still use PARP inhibitors in both situations. But once somebody has it in the genetic makeup, then family members need to be tested. Somatic mutations are happening in the cancer cell. So those mutations, if they're happening in the cancer cell, but they're not in the genes, then the transmission to your family members is impossible.
Oh, good. Okay. So Rob asks if this trial works, if this drug works, will it work on all the tumors a person has, or some of the tumors are more resistant?
That's the most common question when I give checkpoint inhibitors. Will it kill other tumors too? Well, we don't take guarantee for that. That's the most, simple answer I would say. It may, who knows?
Okay, that's what the trial is for, to figure that out, right? So Kara asks, what were the TTI 621 responses in animal studies?
So that I have to look up because responses like they're not. So animal study responses, even whatever response and animals have, most of the times, like when these studies go through phase 1 and 2. So this study TTI 621, it was having a phase 1 cohort which has closed now. Now it's going into phase 2. So responses in animal, I would have to look that up again, but I would say here that it really doesn't impact what response you will have in a human.
Okay.
Because animal studies are mainly done to see if the drug is active in that disease. If you don't see any response in the tumor in the animal, then that drug is dropped there and then. But if there are responses happening in the animal, then they come into phase 1, which basically sees that what dose is safe for humans, and then it comes into phase 2. If it is, once they finalize that dose, then they come into phase 2, where they see that whether it's active in that particular disease, and then they go to phase 3, which is how the drug is doing against standard of care.
Okay, I got very excited about this trial when it was in phase 1, because we had a sarcoma researcher, Matt Van der Rijn at Stanford, do a mouse study. Are you aware of that one? And he did an anti-CD47 and on mice with metastatic tumors in these mice of leiomyosarcoma. So the mice had lung tumors with LMS, and it got rid of just about 99%. It was pretty amazing. So this is why this was about 9 or 10 years ago. So I've been waiting for trials to start testing this out in people. So I'm very, very excited about it.
This is exactly, this is the kind of response. That's what I try to tell people also, and my patients also, that again, what we do in the animals is to see responses. If you look at the immunotherapy checkpoint inhibition in 1995, you go back to Jim Allison and see like what he was doing in melanoma and using checkpoint inhibition over there. Those mice were responding like anything. They would say that we found a cure for stage 4 melanoma. But now in humans, 20 years down the line, we know it works very well, but it doesn't work that well as it worked in mice. So it's animal studies are mainly, when you look at animal studies, you should see if there is a signal. If there is a signal, then we should use that.
Okay, Cindy asked a question. I'm not sure I understand it. What is the pseudo progression on terms of this trial?
Yeah, pseudo progression is a term that came out of pseudo progression is a term that came out of checkpoint inhibitor therapy, mainly in melanoma. So I also practice skin cancers. That's why I know a little bit about melanoma too. So pseudoprogression came out of melanoma, where basically when we were giving checkpoint inhibition, there was inflammation happening in the tumor because now the T cells were able to see the cancer cell better. So when the inflammation happens, I mean, there is no way on an imaging to figure out like what on an imaging, there is no way to figure out whether this is the increase, the growth in the tumor size is because of inflammation or is it the actual growth in the tumor. That is why after 6 weeks, even if we saw a little bit growth in the size of the tumor, we kept going with the checkpoint inhibition therapy. And then we saw that the tumor started really shrinking. So that is what we know as pseudoprogression. In TTI 621, they have not claimed so far of any pseudoprogression. So hard to say. I mean, I don't think we have seen anything. And plus, its chemotherapy is being given. So we know that, when we give chemotherapy, tumors, if they are responding, they either stabilize or they should shrink.
Okay, thank you. So we're at the end of our hour, and I want to thank Dr. Mangla so much. Everybody give a virtual, you're all muted, so give a virtual applause. So there we go. And thank you, Dr. Mangla. If we have follow-up questions, I'll let people write me, and then I'll write you, and we can see if we could get some answers. But you've been very comprehensive, and I can't thank you enough.
Thank you. No, thank you so much for inviting me. And again, like we are here in Cleveland in university hospitals. If anybody is close by in need of a trial, we are absolutely here to help.
Yeah, both those trials sound very exciting.
Sure. Yeah.
Okay. All right. Thank you. Bye, everybody. Thank you for coming.
Thank you. Thank you.